Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Effect of Pathological Tumor Response and Nodal Status on Survival in the Medical Research Council Adjuvant Gastric Infusional Chemotherapy MAGIC Trial by Smythe et al. My name is Florian Lordig, and I am Professor of Oncology and Director at the University Cancer Center Leipzig, University Hospital Leipzig in Germany. I am a medical oncologist with a focus on gastrointestinal cancers. The MAGIC trial established perioperative chemotherapy as a standard of care for patients with resectable gastroesophageal adenocarcinoma. The aim of this treatment is to shrink primary tumors in order to achieve complete resection with clear margins and to eliminate clinically occult micrometastases, which may result in recurrent metastatic disease. However, the identification of patients at risk for relapse remains challenging. The team of Nicola Valeri from the Institute of Cancer Research and the Royal Marsden NHS Foundation Trust in Surrey, United Kingdom, evaluated whether pathological response and lymph node status following neoadjuvant chemotherapy are prognostic in patients treated within the MAGIC trial. The MAGIC trial was an open-label, multi-center, phase 3 randomized trial comparing the effect of 6 cycles of perioperative epirubicin, cisplatin, and infused 5-fluorouracil chemotherapy plus surgery to surgery alone in patients with resectable gastroesophageal cancer. Patients treated with perioperative chemotherapy demonstrated improved overall survival compared to patients treated with surgery alone. Consequently, perioperative chemotherapy is now recommended for patients with resectable cancers by both National Comprehensive Cancer Center Network, NCCN, and European Society of Medical Oncology, ESMO guidelines. However, 2 key questions remain unanswered. These are whether patients at higher risk of recurrence following perioperative therapy and surgery can be identified. Secondly, whether these high-risk patients might benefit from treatment with a different regimen. In an attempt to address the first question, the pathologic tumor regression rate was assessed in resection specimens. Representative blocks with primary tumor or complete pathological response were collected centrally. Hematoxylin eosine stain slides were reviewed by 2 pathologists who were blinded to the treatment arm. They graded pathological response according to the Nodal tumor regression grading system. Differences in patient survival according to tumor regression were assessed using the Kaplan-Meier method and compared using the log-rank test. Univariate and multivariate analysis using the Cox proportional hazards method were performed to establish the relationship between clinical pathological characteristics, tumor regression rate, and presence of lymph node metastases on overall survival. Variables with a p-value of less than 0.05 in univariate analysis were included in the multivariate analysis. Overall, 330 patients had tissue available for tumor regression grading, representing 70% of patients who underwent surgery within the trial. Consistent with the entire MAGIC trial population, most patients were male, The majority of tumors were gastric cancers and intestinal type. There was no significant difference in overall survival between patients treated with chemotherapy with and without tissue available for analysis. In chemotherapy-treated patients with a good histopathological regression, grade 1 or 2 according to Mandart, median overall survival was not reached, whereas for patients with a poor regression, Mandart 3, 4, or 5, median overall survival was only around 20 months. The inter-observer agreement between the two pathologists for tumor regression grade 1 to 5 was substantial. Interestingly, pathological response to chemotherapy was not significantly associated with any clinical pathological variable, including age, gender, site of tumor, or histological subtype. On univariate analysis, lack of tumor regression and lymph node metastases were negatively related to survival. On multivariate analysis, only lymph node status was independently predictive of overall survival, with a hazard ratio of 3.36, a 95% confidence interval of 1.70 to 6.63, and a p-value lesser 0.001. What do we learn from this study? First, it confirms that the nodal status after neoadjuvant chemotherapy is a robust prognostic marker. Patients with lymph node metastases after 9 weeks of platinum 5-fluorouracil-based chemotherapy have a very critical prognosis. Prospective evaluation of whether omitting postoperative chemotherapy or switching to a non-cross-resistant regimen in patients with lymph node positive disease whose tumor did not respond to preoperative chemotherapy may be appropriate. One limitation of this study is the relative sparseness of tumor material available for analysis. While other and more complex regression scores, like the classification system proposed by Becker et al., require analysis of the whole tumor bed. This was not possible here. Only one block from the resection specimen was made available for central analysis. This is one of the reasons why the investigators were forced to use the Mandart regression score, which was originally developed for assessing pathologic response in esophageal cancer following neoadjuvant chemoradiotherapy. The quality of surgery in the MAGIC trial was previously debated and criticized. Details on lymph node dissection were available for 272 patients. In more than 50% of patients, fewer than 15 nodes were dissected. Lymph node specimen may therefore not be representative for the true nodal status in the MAGIC trial. Another potential limitation is that tumor regression grading is challenging in Lawrence diffuse type tumors, which may have significant stromal elements. The presence of signet ring cells, which have in several theories been associated with reduced rates of response to chemotherapy, were not evaluated at all. A final limitation of the analysis is that the investigators were unable to include all patients from the MAGIC trial in this study, as they did not receive material from the entire patient cohort. This limits to a certain degree the robustness of the data. In conclusion, this study demonstrates that in gastroesophageal cancer patients treated with perioperative chemotherapy, the lymph node status in the resection specimen and not the regression of the primary tumor is the dominant prognostic factor. Node-positive non-responders to chemotherapy represent a poor prognosis group. Future randomized trials can accurately inform us if changing or intensifying treatment for non-responders will result in improvements in overall survival for these patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.